Hello and welcome to a whole new edition of the H-Man podcast. Today we talk about vertigo. It's here. We're going to talk about this uh, stifling condition. I want to give a short story, just quick, before we start. I was treating a patient for back pain one day, and uh, while we treating his back pain, he was lying on his stomach, and when he got up, he felt so dizzy, violent attack or episode of dizziness, to the extent that it made him vomit. It was really messy. However, when that happened, I immediately changed course, stopped treating lower back, and I tested him for vertigo. We did the positioning maneuver, Epley maneuver, the most popular one, and he was fine. He came for one more follow up for the vertigo, and everything was taken care of, and he went back to 100%. And then after that, we continued treating the low back pain. So I want to talk about the anatomy of the inner ear, which is called also labyrinth. So as you can see, the labyrinth consists of semicircular canal. They are capillary size tube. Each of them is about 0.25 millimeter in diameter. Each canal has an ampullated dilated ending which houses hair-like receptors called cilia. The cilia detects angular acceleration and deceleration of the head. Each canal articulates with the ampulla. The canal, the canals, semicircular canal, works in functional pair. For example, anterior left works with the posterior right, and the anterior right works with the posterior left. The entire ear, the entire inner ear is the size of a nickel. And here you can see a better picture of the inner ear. It starts with the cochlea. Here is the cochlea. And then you have anterior canal, horizontal canal, and posterior canal. And here's the size of the nickel. It's the same size of the nickel as you can see in this picture. I want to talk about how does it work. So we can't do that without talking about the hair cells. So the hair cells are located in the ampulla. And that ampullated portion, dilated portion in the beginning of each canal houses the hair cells. So the cilia is embedded in a membrane called cupula. Cupula weighs the same as the endolymph around it. So when the head position changes, the cupula stays suspended in the same position because the endolymph, which is the fluid, is the same weight as the cupula, the membrane that houses the hair cells. So the hair cells are connected to the cilia, okay? So the cilia affects the movement or gives information to the hair cells, okay? Those two are almost inseparable. If cupula weight changes, it gives a false sense of head acceleration. Semicircular canal does not detect any gravitational forces. So while you're standing still, there's no information or anything that the semicircular canal detects in that case. So there is a famous example, when someone drinks too much alcohol, it causes disturbance in balance, especially when the eyes are closed, because now you don't even have the visual input of head position. So what happens during alcohol when someone drinks too much? The alcohol diffuses in the cupula and makes it lighter, so it gives a full sense of spinning. So now the cupula, as you can see here in the picture, is lighter than the endolymph, which is the darker purple color here. So it can move much easier, like almost like it start floating around. And that actually gives a sense of floating, when someone closes their eyes when they're under influence of alcohol, drinking too much, then that's what happens in that case, physiologically. So to summarize, semicircular canal detects angular acceleration and deceleration. Here in the picture above, it shows you the otolith organ. And I have to mention that it's very important because it's inseparable from the vertigo. So if you want to understand vertigo, you have to understand where those crystals come from. So here is a quick review of how the hair cells, when they're displaced, how they work. Hair cell displacement towards kinocilium equal canal excitation. Displacement away from kinocilium equal canals inhibition. And again, they work in functional pairs. So one is inhibited, one is excited. So right posterior is excited, left anterior is inhibited. And this way you don't lose balance and you can still look at your surroundings and you can detect the movement, but you don't lose balance. Head movement in this case. So at rest, you can see the kinocilium is aligned straight. It's stimulated when the hair cells move towards the kinocilium, and it's inhibited when the kinocilium moves towards the hair cells. Okay, so moving on. So disturbance of inner ear function does not. So disturbance of inner ear function does not usually cause hearing dysfunction. Mostly, it causes illusion of spinning, which is vertigo. So if there is no hearing loss or hearing difficulty or any effect to the hearing sense of hearing, then it's most likely it's just coming from the inner ear, which is the vestibular system. So other sensors outside of the semicircular canals, okay? And here I have it circled out. So as you can see, the otolith organ is circled out. It consists of two organs. You have utricle positioned in horizontal plane and saccule placed in the vertical plane. Together makes the otolith organ. And I'm going to say what exactly is that. Here you can see um, like a magnified picture of the saccule and the utricle. So otoconia are crystal-like particles attached to the hair cells. So the saccule and the utricle does have hair cells, same like the inner ear, the semicircular canal. The difference here that they have otoconia, crystal-like particles that attach to the hair cells. The weighted hair cells make them sensitive to gravitational forces. So that's the key part, that these crystals, calcium carbonate crystals, gives the function of gravity uh, gravity sense. Like if you're upside down, the weight of these hair cells will go down to the opposite direction, giving sense to your brain that you're in upside down position. Also, these hair cells are influenced by acceleration and deceleration. However, very important difference between the hair cells in the otolith organ, which is right here, is different than the semicircular canal, which semicircular canal works in angular way. The otolith organ works in vertical and horizontal. Utricle will detect horizontal. So if you're in a car speeding 0 to 60 degrees, uh, 0 to 60 miles per hour, then your utricle will detect that. If you take an elevator in a high rise and going really quick, your saccule will detect that sense and change of gravity as you ascend in the elevator. So those otoconia we just mentioned right now. So otoconia are the crystals. They are attached on the top of the hair cells outside of the semicircular canal. If they decay with aging or get dislodged due to a trauma and escape the utricle and the saccule to the semicircular canal, now they came out of where they naturally are and they have a function and they have a decay or trauma that caused them to get dislodged and now they're out of where they're supposed to be and they go into the semicircular canal. In that case, now we changed the weight of the semicircular canal it will create a pressure inside of that fluid inside of the canals, and that will cause vertigo. To recap, semicircular canal detects angular acceleration and deceleration of the head. Otolithic organs detect gravitational forces, i.e. body position in space, and linear acceleration and deceleration of the body. Disease that affects the semicircular canal will cause sense of dizziness. Disease that affect otolithic organ will result in imbalance and dizziness. Okay? So here are some common disease that affects the vestibular system. Number one, and the most important one, and that's the main topic today, is BPPV, which is vertigo, benign, paroxysmal, positional vertigo. And it's called positional because only it happens when you change position. So the site is the crystal went inside of the semicircular canal, you move the head, it causes dizziness and vertigo. Vestibular neuritis is an infection or inflammation of the vestibular nerve and the otolith organ. The symptom will be vertigo and imbalance. Meniere's disease, it affects the entire inner ear and the cochlea, and that will cause hearing loss in addition to imbalance and vertigo. So hearing loss is not usually with the vertigo symptoms. It's like the BPPV. So the vertigo is a symptom, but BPPV is the condition. But normally people use, or doctors sometimes use them interchangeably. So BPPV is vertigo. However, Meniere's disease gives vertigo and hearing loss. Labyrinthitis is inflammation of the canals and otolith organ, and it causes imbalance and vertigo. Why? Because it also affects the otolithic organ, which houses the saccule and utricle, the ones that detect linear acceleration and deceleration and gravitational force, body position. Okay, that's where the crystal actually comes from, and it goes to semicircular canal in the case of BPPV. Okay, so I'm going to discuss the BPPV today and its treatment and diagnosis and treatment. So one more thing that we just want to go over quick is the function of vestibular ocular reflex. Gaze stabilization with rapid or slow head movement. So the vestibular system works with the eye movement to help you keep your eye focused on one target as you move, as the head moves. This is tested clinically with head impulse test. Positive test when corrective saccades occurs as a compensatory pattern. So positive test happens when you turn the patient's head right or left quick and asking them to keep their eyes on one target. So if you turn the patient's head right and then it delays, unable to keep focus on the target and there is a delay and a corrective eye movement towards the target, then that is positive and that should be investigated further. And that's also part of the screening when someone has dizziness. Postural control is mostly a role of the vestibular system as well. So now we're going to talk about something different than the ocular reflex, okay, which is nystagmus. It's a very important sign of BPPV. Nystagmus is a corrective eye movement due to disturbance between neural tonicity between both vestibular inputs, left and right. Eyes will move towards the higher tonal activity. BPPV or vertigo will cause increase of tone of the same side. Okay, so basically with a change of body position, the crystal is now loose inside of the semicircular canal. If you're just standing or sitting, now the crystal is kind of like settled somewhere in the canal. The change of head movement or body position will cause that canal to travel, the crystal to travel inside of the canal. So what happens next is nystagmus, because now we have increased tone. Like your body, one side of your vestibular system, like the right side, for example, will be giving a lot of information that you need to look right, but also the left is trying to counterbalance that. So you'll see the eye kind of like bouncing back and forth like that. That's like the simplest way of explaining it. Of course, there is like sometimes movement, like torsional movement, rotatory movement. Diagnostic and treatment maneuvers of BPPV. And we're going to only discuss today posterior canal. Why? Because it's 80 to 90% of the cases of vertigo happens in the posterior canal. It's posterior canal BPPV. The position of the canal allows the crystals that dislodge uh, otoconia travel and settle easier there. Because of the position of the posterior canal, as you can see in the picture, that's where usually the crystals tend to settle, and that's where 90% of the cases of vertigo happens. Symptoms are usually vertigo, spinning with changing head position, nausea, sometimes in severe cases will be vomiting, involuntary eye movement, which is nystagmus, we just explained that, imbalance. Symptoms usually last for 10 to 30 seconds. So the episode of dizziness does not last longer than 30 seconds. If it does, that is a different problem. Here I'm doing the Dix-Hallpike test for the left posterior canal BPPV. So first we have the patient in long sitting with head turned 45 degrees to the left. We lower down the patient to flat in supine position and have the head lower than their body. So we get the forehead lower than the chin. If that is positive, then we have positive posterior canal BPPV. Okay, so if that's the case, now the treatment is basically we want to get this crystal, this otoconia, out of the posterior canal from the left side of the left side. So we start with the same position, long sitting, patient head turned 45 degrees to the left. We lie down the patient with the head lower than the shoulders, ideally forehead lower than the chin. Okay, we maintain that position and we wait until the vertigo stops. We wait until the symptoms subsides, and that usually takes 30 seconds. So we wait 30 seconds or until the vertigo, the spinning goes away. Patient says, okay, I don't feel any spinning anymore. Next step, we're gonna turn the head to the opposite direction, 45 degrees to the right. So we're gonna turn them 90 degrees, 45 degrees to the right, and wait for the vertigo symptoms to subside or 30 seconds. Okay, now fourth step will be side lying. So we're gonna ask the patient to rotate or turn their body and go on their right shoulder. So now instead of they being flat, we're gonna ask them to turn on the right side. Now next, of course, again, we're gonna wait until the vertigo symptoms subside or 30 seconds. Next, we have the patient sit up. Make sure we support the patient as they sit up if there's any sense of imbalance or dizziness. If the treatment is positive or it was successful, upon sitting up, symptoms should subside or should not experience any signs of vertigo or symptoms or any or like it has to be like improved by a lot. This way it means like we are doing the right treatment for it. The treatment can be repeated twice, and the follow-ups usually could be from 1 to 3 visits. Vertigo episodes in pupillitisis lasting, tend to be longer lasting, often persisting for more than a minute. This contrasts with the brief episodes, typically less than a minute, seen in canalithysis. So vertigo can happen in the posterior canal in two ways. It can happen in a short episode, which is 30 seconds. In that case, we call it canalithysis. If it takes longer than 30 seconds, up to a minute, and it's less severe symptoms, then in that case, it's cupulolithysis. And that means like the crystal is actually stuck in the cupula, in the ampulated ending of the semicircular canal, and it's not exerting a lot of pressure inside, but it can last for longer. Okay, so now we put more weight. It's opposite to the what happens with alcohol. Alcohol makes the cupula lighter. In that case, the cupula became heavier. So in that case, it takes longer for the vertigo signs, the dizziness, to subside. Testing is repeated in cupulolithysis with half Dick's pike whole pike test. Keeping the head elevated and forehead is higher. Uh, the forehead is higher than the chin. So in this case, to confirm, like let's say we did have like just a test of Dick's whole pike, and patient is feeling dizzy, but it takes longer and it's less severe. We confirm it by doing it again by lifting the forehead higher than the chin. In that case, patient feels it for a minute or longer, it's cupulolithysis. Treatment of right posterior canal cupulolithysis. So now we're going to treat the right side. So patient is sitting first. Next step, we have the patient turn the head 45 degrees from the affected side. In that case, will be left. And so we want to make the affected side closer to the ground. So we turn the patient left. Now having the patient lie on their side with a 45-degree angle to the left. Now we brought this way, we're treating the right side. We wait until the vertigo subsides for 30 seconds, and then we swing the patient to the completely opposite while maintaining the same head position, which is left, that case, and have them wait until vertigo symptoms subside or 30 seconds. And then we bring the patient to sitting. Successful treatment is confirmed when the symptoms has decreased or no symptoms at all. Again, we will do 1 to 3 follow-ups after the initial visit. I know this topic can be difficult. A lot of people tell me like, oh, we tried Epley maneuver on our own by using a YouTube video. And I usually really advise to see a practitioner who can treat vertigo and do the testing and treatment maneuvers. I hope you enjoyed watching it and it was beneficial. Until next time, if you have any questions, I have my information in the description. Let me know and take care.